You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeely, and today we're joined by Dr. Jennifer McNeely. She's an associate professor in the departments of medicine and population health at the NYU Grossman School of Medicine. Her article in the Journal of Addiction Medicine is entitled Medication for Opioid Use Disorder for Hospitalized Patients at 6 New York City Public Hospitals with an Addiction Consult Service. It's published in the September-October 2025 issue of the Journal of Addiction Medicine. So welcome, Dr. McNeely, to the podcast. I want to start by giving you a moment to introduce yourself and to tell our audience about your interest in addiction and your journey in the specialty.
So I guess my path into this was a little bit different from most. That I actually started with a strong interest in doing work in drug policy reform after finishing, graduating from college with really no intention of going to medical school. But I was working as super interested in drug policy. I was working in a drug policy think tank based at the Soros Foundation back then, which subsequently sort of morphed into what's now we know as the Drug Policy Alliance. But I was doing that work, like looking at how to really improve public health outcomes related to substance use, and also volunteering in a harm reduction program in New York, the Lower East Side Harm Reduction Program. And through doing that work, it was sort of a combination of feeling a little frustrated with drug policy reform and sort of the pace of change. This was back in the early 90s. And also meeting physicians largely from Europe who were treating patients with addiction in their general practice, were prescribing methadone as part of primary care practice, and also sort of meeting a couple of physicians who are doing really great work in the U.S. with the harm reduction programs. And those things really kind of opened up this window to me into the potential power of physicians doing addictions work, providing care, and also changing things for their individual patients, but the voice that they had and the credibility that they had in the policy and in the research arena. So it's through a number of years doing that work that I decided that I would invest the time in going and doing post-bac, then going to medical school, and so on. So I did post-bac and then went to medical school at Einstein, and I went to residency in Boston at Brigham and Women's for primary care residency, sort of maintaining an interest in addiction medicine throughout that time. And when I finished residency, I did a research fellowship that was more focused on research related to addiction, and that was actually when I came to NYU, started to work at Bellevue Hospital in what was then our very early version of an office-based opioid treatment program in primary care at Bellevue.
All right, very good. Now, you mentioned to me that the city hospital system was interested in inpatient intervention, and this spurred a research collaboration. Can you talk about this collaboration and how it relates to the work that you've been doing?
Yeah, for sure. So this was really a very satisfying collaboration with a large hospital system. And I want to acknowledge my collaborators in the hospital system, especially Dan Schatz, who's a co-author on this paper, who is still a leader in that system in addictions care as a medical director for their addiction services. And also, just before launching it, I want to make sure to acknowledge the really important co-authors. So Yasna Rostamabadi, who's the first author on this paper, She worked with me on this study as a postdoc. She's now doing her residency in psychiatry at Yale. And also Carla King, who's the senior author on this paper, who was a PhD student and still is for a little while longer. But they made really important contributions here. But really, I think the involvement of the hospital system was key, and this research could never have happened without it. That this was back in 2017. The hospital system was looking to make really worthwhile investments in improving care for substance use, and especially targeting opioid overdoses, which had spiked in the city at that time in New York City. And so they were looking across their system at where the care gaps were and looking at their inpatient medicine population, especially, and seeing that they have a lot of admissions of patients with substance use disorders, and that they really didn't have robust services in place. And there were some models out there, largely started at OHSU and Ora Englander's work, and at Boston Medical Center, Zoe Weinstein and Alex Wally had sort of pioneered these addiction consult services, and that seemed like a very good fit for the New York City hospital system, H&H, to adopt. So they had funding and were able to implement it broadly. So eventually it was at 6 hospitals, and these were large addiction consult teams with each team having a medical provider, a social worker or addiction counselor, and a peer. And each hospital had 3 of those teams. And they were able to spread it not to all the hospitals in their system. It's a huge system, so there's 11 hospitals in total, but to the 6 hospitals that at that time had the highest volume of substance use admissions. So we had ongoing conversations that sort of predated this study about ways that they could improve services in their system. So the funding opportunity came along. We were able to write the grant together, and it was funded by NIDA as an R01 as a real research collaboration where we worked together to sort of develop and decide what the model was that was the best fit for their system, and then to rigorously evaluate it with the research funding as it rolled out. So I think, the real beauty of that, of being able to collaborate so closely, was that the hospital system was thinking about really what is most feasible and would meet the needs for their patients. And they were the ones investing in the intervention. And as the researcher, I was able to bring in sort of more expertise, or what's for the field, what is the sort of best thinking about what makes this approach effective, and also to really document its effectiveness as it was running, and to feed that information back to the hospital system. And we showed that these services were effective at increasing initiation and engagement in medication for OUD treatment. That's the primary outcome. And they have kept it going. So the system has maintained it at the original 6 hospitals and is now expanding it to more hospitals within their system. So I think having it's not real-time feedback, but having the ongoing feedback and their rigorous evaluation hopefully helped them to feel like they were investing their funds in the right place here.
All right, great. Now, you also mentioned that there was an increase in buprenorphine use with the consult service involved. So I suppose providers were more comfortable with methadone as well. Can you discuss what that means for patients as far as having more options and more say over their care?
Yeah, I think that was one of the really interesting things that came out of this analysis, which is a secondary analysis to the primary outcome of the study, was looking at the patterns of medication for OUD in the hospital. And, I think it means a couple of things. One is that patients had more of a choice. That I think there was more patient-centered discussion of what medication would be the best fit for them. And so there's more options on the table, whereas previously, at least anecdotally and through some of the data that we looked at early on, methadone was really the go-to sort of automatic medication that would be chosen. But it wasn't chosen because patients necessarily wanted to start a new course of treatment with methadone. It was mostly, we presume, used for managing withdrawal symptoms, which is important, but it doesn't fully utilize the opportunity for the hospital admission that can be the start of a treatment episode with medications. And for that, being able to give patients a choice to talk to them about after they leave the hospital, what's going to work better for them. It's going to be methadone maintenance or buprenorphine maintenance, and then having the ability to offer that and to start it right away in the hospital, we think made a difference in terms of patients and engaging in treatment when they left. And through the main study, the primary outcome did show much higher rates of initiation and 30-day engagement in MOUD for patients who were in the catch hospitals who had the intervention. So I think there's some credibility to that, reading into it, that the use of more buprenorphine probably reflects the sort of more patient-centered discussions of what a treatment plan could look like for the longer term. But I think also if this study was done in years before, it was easier in those years to start buprenorphine because we had fewer problems with precipitated withdrawal with fentanyl. It was there, but not to the degree that it is now. But nonetheless, it's challenging for providers, hospitalists who don't treat a lot of addiction to feel comfortable starting buprenorphine when what they've kind of always done is to give a low dose of methadone. So I think that having the consult teams and that comfort and expertise allowed that to happen and to get patients onto medication that they chose instead of sort of just a default. And many of them did choose methadone. It wasn't like methadone went away, but there was more of a mix, and that's the mix that you'd expect to see more of a mix because people have different preferences.
Okay, and those are all great points. And from a practical standpoint, you mentioned that there may be a fear that starting a consult service will make patients stay longer, but the opposite is often true. So can you speak to that? That fear that I'm not sure where it comes from, maybe from administration or maybe even from the primary services, maybe not wanting the patient to be stuck in the hospital longer. But could you talk a little bit about the trend that you see and, how that affects length of stay?
Yeah, it's interesting. We heard that concern a lot sort of as these services were starting. We know that that's a meaningful measure for hospitals because days in the hospital there's financial consequences to that. And I think as providers, when I worked in the hospital on the medicine floors, I do remember cases of patients being sort of held for a longer time while trying to come up with a better discharge plan, like to a inpatient rehab type setting. So that was a real fear. What we saw with this was that in this analysis, there was no significant difference in length of stay for patients who had versus did not have a consult. So, and it actually in the primary outcome analysis that used Medicaid data, we saw that there's actually a lower median length of stay with the consult service than without it. It was 4 days with the consult service and 5 days without. So I think, it's better care. It doesn't need to take more time necessarily. And that with a consult service, especially here, like this was not just a medical provider, but also a social worker and a peer, all being able to focus on the patient and really thinking about their discharge planning from a substance use standpoint from the first time that they met them, so that you're able to set up sort of better plans. Maybe this patient only needs outpatient treatment. They don't need an inpatient placement. And so it actually can result in more favorable length of stay. So I think that's an important finding. It wasn't our primary outcome, but it's a meaningful one for hospitals that are thinking about whether this is worth investing in, and are they going to lose money by doing it?
Well, great. And I suppose that we can't ignore the practical either. So I think that studies like this illustrate the benefits of a consult service, and that can help administrators make more appropriate decisions. So I definitely see the benefit there.
I mean, the other thing that's worth pointing out is that in our analysis we published in JAMA Network Open, but we did an analysis looking at acute care utilization for patients, again, sort of same patient population, but using Medicaid data so we could capture all of their post-discharge care utilization. And in that, we showed reduced emergency department admissions as well for a full year after the full year that we examined it. So that's also, from a health system or a health insurance standpoint, that's a meaningful potential financial savings too.
Okay, good. And, one of the big findings was that there were racial and ethnic disparities. So rates of MOUD prescriptions are lower in non-white populations, and having a consult service alone won't fix that. So can you discuss whether some specific intervention could be suggested to accommodate for the disparities that you're seeing?
Yeah, so just to recap, what we saw in the analysis was somewhat lower rates of calling the CATCH consult, the addiction consult service, and also lower MOUD orders in patients who were Black in comparison to white patients. And we had pretty good diversity in race and ethnicity in the sample. It's a New York City public hospital sample. So the one, I think, important distinction here is that there are limitations to this. One is that the data that's captured in the electronic health record on race is not great, that we had about half of the sample had a race marked as other, so that makes it hard to do really sophisticated analysis based on race. But I think the difference that we saw in comparing Black versus or other versus white was certainly there, and seeing lower rates of MOUD orders. And the other thing is that we weren't able in this analysis to distinguish between people that were receiving MOUD before hospitalization versus starting it when they're in the hospital, so initiating new treatment in the hospital. So what we can't say is that did the consult service just sort of, were patients continuing on MOUD, which was the basic trend is that you see in the population that we know is that rates of MOUD are lower in racial ethnic minorities compared to white people in the U.S. And so is this just kind of reflecting that overall trend? I think it is. Did the consulate service alone correct that? I think here it did not, that the disparity was persistent. And it needs to be, it's something to look at and to continue to work on, both in thinking about, for providers, are they calling consults consistently? And then when the consult is called, do the consult providers even are they able to answer the questions and sort of answer the concerns of patients about treatment, and begin to address some of those more structural inequities. The unfortunate thing is that in the hospital, you can control a lot while patients are in the hospital, but then they need to, once they leave, also sort of have welcoming environments to continue care, and that's not always in place outside the hospital walls.
Now, is there anything that you learned through your study that would help clinicians who are practicing in this space in treating their patients?
Yeah, I think for me, one of the big takeaways from doing this study was that hospitals, really any medical care points of contact, but especially hospital admissions, are a really important touch point for reaching people who aren't looking for addiction treatment when they walk in the door. They're almost always being admitted, for some other reason, for a medical reason that may be totally unrelated to their opioid use disorder. But what we see is that by having knowledgeable and caring providers, that hospitalization can turn into a new treatment episode that will frankly save their life. And that we saw much higher, over 3 times the rate of medication for OUD here among patients that had a consult, that saw the catch team. And I think what that says to me is that don't sort of accept an automatic no from patients who say that they're not interested in treatment or not interested in medication until a knowledgeable provider, or even better, a knowledgeable peer and medical provider, have had an informed discussion with them about it. Because sometimes people they have a picture in their mind of what treatment is, what it looks like. They've decided that it's not for them. But that can change when you sort of engage them in a discussion about the things that they care about, and have the knowledge to actually make a plan with them, and to do shared decision making, and also to follow through on that with them. So I think that's one of the beauties of having these consult teams, is that there's a lot of opportunity there, even for patients who say that they're not interested in treatment, to actually understand what they are interested in and to do things that are meaningful for their health and for their overall outcomes. So I always, after doing the study for those years, I always tell my medical colleagues, don't take a patient's sort of first answer of no, I'm not interested in treatment, or no, I'm not interested in any services for my substance use, until a addiction provider or a peer has had that conversation with them.
That is great. So, Dr. McNeely, thank you so much for being a guest on the podcast. Again, Dr. McNeely's article is entitled Medication for Opioid Use Disorder for Hospitalized Patients at 6 New York City Public Hospitals with an Addiction Consult Service. Again, it's in the September-October 2025 issue of the Journal of Addiction Medicine. Thank you.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.